First of all, thank you for the invitation to come here. It's a fantastic opportunity for me to be here in Portugal. I was here a few years ago, but had a good opportunity to meet a lot of colleagues, but also new colleagues here. And I have to say, a disclaimer, I'm not the son of David Systrom. Kathy, I promise. We might be cousins, actually. Syström is a very Swedish last name, actually. So we are probably cousins, David. So that feels good, I think. So I will talk a bit about what we are doing in Uppsala and in collaboration of the Open Medicine Foundation research collaboration centers. And today I will focus on a study that we have been doing during the pandemic. So we have been going for home visits to patients, the most critical ill patients that we couldn't see at the clinic, and also that we didn't have opportunity to invite for our other studies. So this was a great opportunity. But I just start with the situation in Sweden right now. We are in a rather hopeful situation, in a hopeful time. First of all, we are learning more and more about post-viral infections. We are learning more about what happens in neurocognition, which of course is one of my interests. But also we are getting acceptance for these patient groups. And I think that's a very important thing. So we see that colleagues that are in other fields are getting interested in doing research on patients with post-viral issues. And it's also accepted by the politicians, partly at least. And it's also accepted by the funding agencies. So we are in a hopeful situation. And I think also just to comment on what David ended his presentation with this morning, this clinical trial that we are conducting, the LIFT trial, I think that's also something that we look very much forward to see the results of. And hopefully that's just the first in a line of trials. Mario just presented what happens in the heart. And as you may know, actually in acute critical ill patients with COVID, you can also get effects on the central nervous system in the brain. Luckily, this is a very unusual situation. But we have patients where you actually can see acute inflammation in the central part of the brain on the scans. This patient was a special case with severe infection where we could actually monitor both viral particles and inflammation in the central nervous system tissue and cerebrospinal fluid. The patient survived and have recovered more or less, but still have sequelae. But long COVID patients, as you know, they don't typically present with this kind of phenomena. They are more subtle in their symptom pictures, and we have already heard very nicely how well the symptom picture overlaps with what we have in ME/CFS. And I think we can really learn from this. And yesterday, Sue Levine presented very nicely the history of pandemics and outbreaks that actually have led to post-viral consequences for patients. So I won't go into that. I just want to conclude it's not a new disease. We are seeing this back in history, and we have to learn from what's happened in history. And last year, I had the opportunity to actually be invited to go to Iceland and to Akureyri, where the Icelandic disease outbreak was in 1948, 1949. And I had the opportunity to meet one of the surviving patients from that outbreak, actually, Asgeir Johannesson, who has been suffering from the disease since 1948-49, but has sort of done well considering the consequences of the disease. So, as you all know here, myalgic encephalomyelitis or chronic fatigue syndrome is a neurological disease, and most often post-viral disease, as we say. But I will focus on changes over time, and this is something that I think we should explore more of in our studies in order to find differences within patients, but also find relationships to what makes patients change when they have good days and bad days. And when we do that, we need to do temporary resolved sampling. So we need to get samples over time, and we need to follow and monitor patients frequently. And one example of a paper we published fairly recently was a 17-year-old girl who has helped us really with her diary to tell us how her situation changes over time. And she's been fantastic supportive of our research, and also her family have helped out a lot with the research. And just to show you how well she has recorded her symptoms in her own scientific way to give us a hint of the variability you see in patients. And I think many of you recognize this also. You had very good days sometimes, but you have also very poor days. So in order to address this, we went for a rather time-consuming and you could say challenging task, and that was to do home visits. And it was partly related to, as I mentioned, due to the pandemic, we couldn't go and invite patients to come to our clinic for investigation. So we wanted to have opportunity to see them, and we went to their homes. And this is in parallel done in collaboration with Australia, as you see in the lower part of this panel here, with Chris Armstrong's Collaborative Research Center. And what we did in Sweden, we had opportunity to go to the patient's home, and we started very early in the mornings, running the whole facility there in their home. So I will show you on the picture later on. And we did multiple blood sampling, blood draws during the day. And the patients were exposed to 3 very mild exertion events. One was a mental test, a neurocognitive test, you could say. What we could see that patients performed rather poor on this, but on the other hand, some of our healthy controls matched gender and sex and age matched controls were also performing rather poor. It was a hard task, actually. It was reading a text and then answering a random question that I had selected for them. That one was followed by a time period of rest, and then there were social interaction tests, and that was a social discussion and also a very well-controlled intake of energy, so a small meal. After that, a rest period, and then the final part is a physiological test with an exercise test on a mild condition, exercise on an ergometer. So very mild condition, low cadence, low force, and for a short while. And then sampling was done during the whole period. And actually the patients, David, they said, it's better than a dental visit. It's better than an IC PET. And actually, they said that this was actually the best thing that ever happened to them during the last years, actually. Because they are so isolated, as you know. So just having us visiting them in their homes and caring for them for a whole day, it was something that they really appreciated. And of course, we are very grateful for their efforts also to be part of this. And none of the patients reported with post-exertional malaise afterwards. So that was, of course, our worry, but they were doing fine. And I think they were excited by the situation, of course, but they did well. And in Australia, Chris will do a similar test, but only including meals, as you see, 3 meals during a day, standardized meals, and then draw blood samples. And right now, we are at this moment, we have collected, in our case, about 3,000 samples. All of them have been analyzed now for metabolic patterns, and statistics is ongoing. And I will show you some statistics just fresh from the laboratory, actually. I don't know how many of you have been in Sweden. This is a map of the west coast of Sweden, Västra Götalandsregionen, as we say. And the reason why we selected that part of Sweden was that at that time there were no clinic in the region, and also we had the opportunity to visit in the close vicinity quite a few patients. So we could go, and we can even see 2 patients per day when we were working very long hours. We packed our laboratory and all the facilities in a car, and we went home to the patients, and we occupied their apartment or house with all our equipment. We loaded the setting in the kitchen normally, and then we had the samples drawn from the patients. And here you see the picture of Hanna Gustafsson, a student of mine who was working with us in this project, and now she's a MD, finished her education. And that's her aunt, who is a nurse, who helped us on the way. And we have also another colleague, Anders, in there. So we took care of the patients in the best way we could, and we used very low budget situations. We used friends and family members and whatever we could to make sure we could do this. It was long days, long hours, a lot of very poor food intake, Burger King, McDonald's, you know, very tired of that. But that was the case. And it was worth it, I have to say. So just to allude to what we heard earlier today, lactate, of course, was one target that we wanted to monitor. And lactate, when we did it acutely at the place, we saw, of course, an increase of lactate significantly, and also remaining high level after each test that was performed. So that matches well what we see in other studies. And I think this is, of course, we can allude to the mitochondrial dysfunction here. But what we have managed now to do is to run in Uppsala, in our in-house test, 630 different metabolites and ratios on top of that. And yeah, I don't have time to go through all of them, but it's based on an internal standard corrected absolute quantitation method. So we can actually tell in micromolar what is the concentration of each analyte, not having only a number and something you have to relate to. So this is a micromolar concentration technique, and it's based on high-resolution liquid chromatography and mass spectrometry, basically. So we are happy to say that this is done now. So we have done all the samples on this. But meanwhile, we have also been developing another set of markers. So we have increased the lipid part of this panel, increasing it with a few hundred more. So now we have about 1,000 metabolites plus ratios that we will monitor. And that is still ongoing. So we will do that. So what's the purpose then of having the possibility to monitor over a time period and monitor the same individual? Well, there's a lot of information there, of course, that we can gain. And one thing is, of course, we can see what happens during the daytime, during the tests. And this is just one marker that I pulled out as an example. This is kynurenine. And those of you who remember the metabolic trap story that Ron Davis and colleagues presented a few years ago, it's very much involved in kynurenes, and kynurenes are very important in ME and post-COVID, as we know. But here we can see, for instance, how these individuals worked out in the kynurenine pathway. You see a significant decrease in kynurenes in patients, while the controls and the athletes are above. What happened in the kynurenes at time point T4, which is the physiological exercise or ergometry, you see that there is an increase in the patients. So the basal level is kept low, and then under exercise, they actually increase the kynurenes for a short time period. We can use it for other things also. For instance, this case, this is a patient number 5 in our study. I forgot to mention that we are running 25 patients, 25 healthy normal controls, and then 25 athletes. And the athletes are actually very kindly, the tennis team in Sweden, the athletic tennis team in Sweden has helped us with being the control or contrast group, you could say, in athletes. So here we have a patient. You see the darker line in the middle here, and you see that that patient is not in the same range and not reacting as the other patients are doing, basically. And actually, when we looked back and saw the history of that patient, it's not a normal patient. It's not what we would say a patient we would include in the study if we knew everything from the beginning. So we can tell and we can see the differences going on inside single individuals also, which is very important. Just giving you a few examples then of things that we are. I will focus on lipids a bit today. So phosphatidylcholines, for instance, is higher in many cases in the patients, as you see, and especially the long chain phosphatidylcholines, lower in the short chain, and that is significant. And phosphatidylcholines is involved, for instance, in membrane lipid construction and sphingomyelin synthesis. You can also look at the data in the way that you separate for gender or sex. And here we have selected men and women, then, as you see, and there is differences between the sexes, as you can tell, and especially in the patients. And here's another phosphatidylcholine. You see a more similar pattern between the sex, actually. Another example, phosphatidylcholine, lowered in the patient significantly. It's a messenger molecule, and it's also involved in inflammation and nervous system control. So it makes sense. if we look at sex differences, we see that there is some differences, but not maybe so obvious here. Sphingomyelins also decreased in our patients, and that is an interactor with choline, which is also an important transmitter. And here you see the sex differences also, not so obvious changes in the between men and women there. And finally, ceramides, which is also lowered in significantly lowered in the patients compared with both the patient controls and the athletes then. And that's also a sphingomyelin synthesis step. Yeah, you have another ceramine and dihydroceramine. And sex differences. So I will jump to this slide, I think, to save time for us. So what we can see, just pulling out some of the markers in the lipid pattern here, we see that it's actually consequent decrease of most of these lipids in our patient cohorts. Some are actually upregulated as the long chain phosphatidylcholines, and some of the diacylglycerides, as you see over there. But most of them are of the others are actually decreased in our study. So what does that mean? Well, in summary, temporal result sampling is very important because it gives us a very high dense information on the patient. And in our findings, just focusing on the lipids, we see that ME patients have a disturbed metabolism that we can monitor. And in the lipid class, we see signals of inflammation, nervous system dysregulation, hypoxia, and oxidative stress. So as a few examples. But there is much, much more to dig out from this data, of course. And when I was invited to come here to Portugal, Joan and I was in communication, and one of my titles that may be the one I'm most proud of, partly, at least, being part of OMF is very important for us also. But I'm also Inspector Equitandi, and you may not know what that is, but that's a very, very prestigious position in Uppsala. It's we have the second oldest riding department, Institute for Equestrians in the world, actually. And I'm the head of that department now. So when I was coming to Portugal, I was contacting Johan and said, I'm very interested in horses. And by chance, actually, Johan had fine contacts, and I will show you soon. This institute started 1663, so it is pretty old, actually, I have to say. And what happened to be a fantastic occasion was that Johan had cousins who actually have a Lusitano farm, breeding farm, just outside Lisbon. And we had the opportunity to go there on Tuesday, and I fell in love with this guy here, a very nice foal, Lusitano foal, beautiful horses. So I end with that, and I just want to say thank you, first of all, to our patients.
Okay, so the floor is open for questions. We'll have about 20 minutes to question. Please be brief. Thank you.
I'm getting a reputation. Thank you.
No.
Thank you, Professor Bergquist, for your presentation. Thank you also, OMF. You have been extraordinary support for many years. I have a question. Please bear with me. I will try to be brief, but brain fog doesn't help. I've also kept track of my symptoms via Excel and done this for maybe 10 years. What I noticed and was always disregarded was that there is a huge correlation between activity and food cravings, insane food cravings. And I decided, saw endocrinologists, saw nutritionists, no answers. And so I did a questionnaire, cohort of about 80 patients, nothing official, obviously, I'm, not a doctor. And 80% answered that following even mild activity there are these insane food cravings. So again, in my non-medical ignorance, I did my best to try and understand, and the only explanation I got was that there seems to be a faulty functioning of the metabolism in relation, or rather mitochondria in relation to metabolizing oxygen. So we function, apparently, mostly on an anaerobic metabolism rather than an aerobic metabolism. Now, that's all I know. There is not a lot of information out there. I wonder if you would comment on this, please. Thank you.
Yes, first of all, it's a fantastic thing. If you can keep records of your situation and your symptoms, that is very helpful, actually. And please share it also if you can, of course, because it's also important. Yeah. We hear similar stories from many of our patients also, that they have this, it comes and goes, and it's also sometimes related to craving, and but also activity very much. So, we can, in our patterns, actually see this anaerobic activities. We can see the mitochondrial dysfunction. Hypoxia is another part that we're looking at in detail right now, with hypoxanthine, which is a marker for that, which I am very interested in. And yeah, I mean, there is absolutely something there. We don't know exactly how it works and what's the reason for having this. Another thing that we are extremely interested in is also following hormonal endocrine differences in the patients. And we see that it seems like the hormonal picture is changing in similar way, and it's also following patterns that are related to activity, fatigability, etc. So hormones are most likely very important also here.
I have here a question for Mario, which is, what are risk factors for developing myocarditis?
I think the male sex, there's a predominance of males, and age. Younger age is associated with, so younger males are the sub, yeah, compared to the others. On risk factors, no, as far as I know.
The heart, the number of incidents of infections with COVID-19?
Yeah, the reinfection is associated with lower risk of myocarditis than the primo infection.
Okay.
More questions?
Faço a pergunta em português, que era para os dois. Na vossa experiência, portanto, que questionários é que utilizam para, enfim, caracterizar esta doença, nomeadamente a PEM, ou caracterizar a disfunção, a incapacidade? Porque eu, na minha prática clínica, tenho muita dificuldade porque não há questionários validados em português, pelo menos em português de Portugal. Não sei se no Brasil, que tipo de questionários já traduziram o DePaul. Acho que o questionário DePaul é um dos mais conhecidos e muito utilizados a nível mundial. Portanto, a minha questão era, que tipo de instrumentos é que estão a usar na vossa prática clínica para objetivar as queixas e para caracterizar a incapacidade dos doentes?
The question was, what kind of questionnaires do they use in order to characterize signs and symptoms? Basically, was that what kind of validated questionnaires do you use to capture the signs and the symptoms, especially the symptoms?
Portuguese or English? Portuguese. Eu acho que esse é um problema em geral, quando a gente fala sobre questionários, né? A língua portuguesa, normalmente, ela não tem todos os questionários traduzidos, e quando tem, alguns não são validados cientificamente, né? Então, na prática, o que a gente faz no nosso centro é nós traduzimos a definição do CDC e transformamos ela num questionário de REDCap, do banco de dados. e fazemos as perguntas aos doentes para tentar caracterizar a fadiga. E existem alguns outros questionários, tipo Mini-Mental, que já são traduzidos, já são mais antigos, são validados, para tentar caracterizar os outros sintomas. Mas para a fadiga crônica em si, você não tem um questionário validado. Você tem alguns traduzidos, mas não validados. Então, talvez... I'm just saying that we, in the Portuguese language, we have a problem. It's just not restricted to chronic fatigue syndrome, but to questionnaires in general, that they are not translated to Portuguese. And a few that are translated are not validated scientifically. So we try to translate ourselves, and it's a task that maybe we should do, try to validate in the Portuguese language.
One brief question, very brief.
David beat you to it. You're next, Monica, you're next.
Quick question for Drs. Oliveira and Santos. So one of the holy grails in this business is precision medicine, identifying subtypes, phenotypes of symptoms in both ME and long COVID. Broadly speaking, at one end is fatigue and post-exertional malaise. At the other end might be orthostatic intolerance. I'm wondering, with respect to the latter, muscle sympathetic nerve activity or any other testing you're doing, Rudolph, help you direct your therapy? And Mario, if we got a lot of compensatory tachycardia, any wisdom about avabradine versus beta blockers in such patients?
Yeah, so that's a great question, Dr. Sistrom. and it's really helpful. And most of the patients that we find preload failure in the ICPET, they have abnormalities in the sympathetic nerve evaluation. But there are some cases that they do have autonomic dysfunction and don't have preload failure. It's pure autonomic dysfunction. So it helps to guide therapy because it's a different phenomenon. And also in our cohort is about 60% that have poor oxygen extraction. So it's not a 100%. So at the end, you can deep phenotype the different types of long COVID and tailor the treatment according to the phenotypes.
Yeah, short answer. Experience-based. When palpitation is a very important symptom for the patient, I start with ivabradine, low dose, or low dose bisoprolol, yeah.
Hi, this is for Dr. Bergquist. A major link in between lipid metabolism and angiogenesis inflammation, renin-angiotensin, is sphingosine 1-phosphate. Was there a reduction in sphingosine 1-phosphate in your cohort?
I didn't hear exactly the last. Can you repeat just the final part?
Sorry, did you see a reduction of sphingosine 1-phosphate in your cohort, or do you, shall I look at your data?
I don't know by heart, unfortunately, but I will look for it actually, because there, as you saw, there are quite a few markers to keep track of in our data set. But we are screening for that, and we are looking for things that will, for instance, report on inflammation and things like that. So, yeah, good point.
Yeah. First, I just wanted to thank Dr. Bergquist for the designing your study, actually going to patients' homes. That's super helpful. So as a patient, thank you. There are a lot of housebound and bedbound patients who can't take part in most studies. So I might have missed it, but I was curious if you had any severe, very severe bedbound patients.
Yeah, so the patients we selected were those that were, of course, tolerant to us to come visit, but homebound and bedbound, many of them. So we tried to reach the most severe possible patients we could get to.
Let me just ask a question to Jonas.
One of the lipid profiles and other markers that you showed are elevated, given the fact that some of them are very the kind of marks for inflammatory disease, do you think in the near future we may have a higher incidence of cardiovascular disease in these patients? Given your markers?
Yeah, I mean, that's a good point. I think definitely, but I would say, Mario probably can correct me, but I think also depending on how, I mean, lifestyle factors and being bedbound, for instance, it cannot be good for cardiovascular reasons. So I think definitely we could see that kind of effects also. Yeah. Well, I just want to add a comment also. Being able to do the home visits, what it actually give us is maybe better levels of baseline, because patients are relaxed when we come to them, and they have not been having the trouble to travel or transport themselves. So we see actually some of the markets we have where we have the first samples taken on baseline, they are lower than what has been reported on for other markers in other studies. But I think that's an important finding in itself.
Okay, we have time for one more question. Okay.
Hi, Dr. Bergquist. A question about the chirinin levels. Are those tied in with sleep issues? Because that's part of the tryptophan pathway.
Yeah, could be. But as you probably know, I mean, the metabolism of quinoline is below serotonin and melatonin, which is more sleep related. And then quinolines are related more into neuroprotection, neurotoxicity, and goes down to quinolinic acid, which is then quite toxic substance actually. So but of course, effects of the transfer from tryptophan to serotonin, melatonin, or the bigger pathway down to quinolinic acids and quinolines are all connected.
That's interesting. Yeah. Thank you.
Final question, can always stop over lunch.
Thank you so much for the opportunity to having the last word before lunch. A question to Rudolf, eu vou fazer em português. É uma complementação de uma questão que foi feita sobre como você faz o clinical phenotyping do paciente. Só para eu entender, o critério de entrada inclui um critério de ME/CFS, como o CDC, ou você inclui pacientes também que não atendem ao critério diagnóstico de ME/CFS, mas podem ter doença cardiovascular ou pulmonar?
O critério do nosso estudo é ter tido infecção por COVID e estar sintomático depois de 3 meses. Ponto. É um critério bem amplo mesmo, propositalmente, porque a gente quer fenotipar o COVID longa de uma maneira mais ampla. Para nossa surpresa, quase que 100% dos pacientes que chegam para a gente é o fenótipo de fadiga crônica. Então, a gente aplica os questionários para caracterizar, mas pontuar no questionário não é um pré-requisito. Então, o critério de inclusão é ter tido COVID e permanecer sintomático. Né? Aí a gente faz toda a avaliação em todo mundo, né? Avaliação clínica com os questionários, faz a avaliação com a ICPET, a avaliação de sistema nervoso simpático. Aqueles que preenchem o critério para disfunção de pré-carga continuam no estudo para randomização, placebo, pirostigmina, e repetem todos os testes depois de 8 semanas para ver se teve resposta.